Welcome, everyone. Today's presentation explores a theoretical and evidence-informed public health approach to understanding and preventing opioid overdose. My name is Whitney Gage, and I will walk you through both the theory and research that guide effective interventions. Here's an overview of what we'll cover. We'll begin with the theoretical frameworks that inform overdose prevention. Then we'll review evidence-based and evidence-informed strategies that have been tested in the communities. Finally, we'll consider program evaluation components and conclude the key takeaways. Opioid overdose have risen dramatically over the past decade, especially with the presence of fentanyl in the drug supply now. Importantly, many overdoses are preventable through timely intervention and access to resources like Narcan. However, we face persistent system-level barriers, policy, stigma, and limited access to treatment that complicate prevention efforts. The health behavior model helps explain why individuals engage or fail to engage in health behaviors like carrying Narcan. Key constructs include perceived susceptibility, perceived severity, benefits, barriers, cues to action, and self-efficacy. This model frames overdose risk as the result of individual beliefs and perceptions. Many people who use opioids may underestimate their personal overdose risk, especially with fentanyl contamination. Awareness of benefits, such as acknowledging Narcan can save a life and can motivate behavior. Barriers like cost, stigma, and lack of training still block action. Cues to action include public health campaigns or stories from people with lived experience. Training plays a major role in improving self-efficacy to respond during an overdose. This model is great for shaping educational campaigns because it focuses on individual beliefs that can be changed. Limitations: it does not fully account for structural issues such as availability of Narcan or broader social economical factors. Additionally, it assumes rational decision making, which may not align with the realities of addiction and environmental risk. The social cognitive theory expands beyond individual beliefs, emphasizing reciprocal interactions between behavior, individual factors, and the environment. Key constructs include self-efficacy, observational learning, outcome expectations, and reinforcement. This theory can help explain behaviors such as carrying Narcan or participating in overdose prevention training. Reciprocal determination shows that behavior is influenced by community norms and policies, such as the Good Samaritan laws. Observational learning occurs when individuals see peers using Narcan or attending community training. Training increases behavioral capability and self-efficacy. Reinforcement from peers, coalitions, and community recognition can sustain behavioral changes. Strengths SCT addresses social context and environmental influences. It's flexible and can guide both program activities and policy strategies. Limitations: programs based on SCT can be source intensive. Observational learning doesn't always translate into action during emergencies. Structural barriers may still hinder individuals from performing the desired duties. This section looks at large-scale interventions, including the Healing Community Study, take-home Narcan programs, and community coalition models. We'll examine what worked, what didn't, and the theoretical foundations behind them. The study implemented over 600 strategies, including Narcan distribution, medication treatment, and safer prescribing. While community campaigns helped reduce stigma, the overall interventions didn't significantly reduce opioid overdose deaths in the evaluation period. COVID-19 disruptions and complexity were major challenges. Evidence shows that take-home Narcan programs reduce overdose mortality and increase community response capacity. They empower lay people with training, knowledge, and confidence. However, barriers such as stigma, inconsistent implementation, and legal restrictions remain. This approach uses community coalitions to implement evidence-based strategies tailored to local needs. It incorporates SCT principles through modeling, reinforcement, and community ownership. The intervention showed small but non-significant reductions in opioid-only deaths, but stronger impacts for polysubstance users. HBM principles appear in strategies that build perception of risk and highlight Narcan benefits. SCT principles guide training, peer modeling, and community-level reinforcement strategies. And gaps remain, especially around addressing structural barriers and fentanyl-related risk. Proposed strategies include expanding peer-led Narcan training, building stigma reduction campaigns, and supporting policy changes. These link directly to HBMI by reducing barriers and increasing benefits, and to SCT by using modeling and reinforcement. Policy advocacy is essential for overcoming structural barriers like cost and legal restrictions. Evaluations should include both process indicators. Theory-based indicators ensure we are measuring constructs aligned with HBM and SCT. Behavioral outcomes like number of reported overdose reversals are key. Stigma and legal barriers are major obstacles. These can be addressed through policy advocacy and community education. Limited resources for training. Can be mitigated through partnerships with local organizations and use of mobile units. Long-term measurements can be improved with mixed method evaluations and follow-up assessments. Preventing opioid overdose requires a comprehensive, theory-driven approach. Both HBM and SCT offer valuable insights, but must be combined with structural and policy strategies. Evidence shows successes, but also highlights gaps, especially in researching marginal groups. Ongoing evaluation and community engagement are essential for proving outcomes. Here is a list of all the references that I used throughout my presentation, and I hope you learned something and you enjoyed my presentation. Thank you for watching.